Our first case is a 58-year-old gentleman who has recurrent diffuse large B-cell lymphoma. He presented in April of last year with progressive cervical and axillary lymphadenopathy. He had an excisional biopsy that showed diffuse large B-cell lymphoma, germinal center origin, double expressor phenotype. A PET scan showed disease above and below the diaphragm, or stage 3 disease, and he was treated with R-CHOP. By October of last year, he completed 6 cycles, and a PET scan at the end of treatment confirmed that he was in remission. About 3 or 4 months later, he presented with new progressive right cervical lymphadenopathy, and his LDH was elevated above its baseline. Core biopsies showed recurrent CD20 diffuse large B-cell lymphoma, and at our request, the pathologist did immunohistochemistry, and it stained positive for CD19 as well. He was referred to for CAR T cells, but lost his health insurance due to loss of employment, and he canceled the visit. By March, his insurance was reinstated, and he underwent collection. He received 1 cycle of polatuzumab plus rituximab bridging at the request of the treatment center, but shortly after starting that, returned with progressive cervical and supraclavicular lymphadenopathy. His LDH was climbing, his cytopenias were worsening, and his performance status was declining. I've listed his LFTs in the bottom slot on the bottom line. You can see has progressive transaminitis. Billy is up at 1.8, and the cells will not finish manufacturing for about another 7 to 10 days. So this is a gentleman who has progressed, has very active disease, and is not responding to bridging therapy.
So I guess I'll start off questions here is so for this patient, so let's say his cells were manufactured, would you proceed directly to the CAR T infusion, or would you actually try further bridging therapy?
It's a difficult discussion, Dr. Padilla. I feel like the most important thing with this patient is that we're not in the driver's seat. I mean, he has primary refractory disease. He's progressed within 12 months of frontline therapy. He has progressed through bridging therapy, and I think your choices are you either give him multi-agent cytotoxic therapy or you proceed with CAR T cells with a higher disease burden. In the CD19 space, we don't there's no reason to believe that the cells would be less effective in establishing a remission, but he likely would have increased toxicity. So I think it would be a difficult decision. Do you give him chemo that he's been refractory to previously, or do you proceed with CAR, assuming the cells are ready? I think it depends on what he looks like. Right. And it's probably, honestly, it's probably a discussion amongst colleagues. You know, what is the best way, the best course for this particular patient?
So what is the other option?
Yeah, I mean, I think the other option is you try to cool him off with chemo. You give him some steroids, you give him Bryce, and you come back to the CAR, 10 days, 2 weeks, 3 weeks later. you know? It's not a good situation to be in, right? We don't want to be in this situation.
All right, so tough case. So Katie, maybe I'll ask you. So obviously this patient lost his health insurance, so that seems like a really difficult situation. I mean, is there anything else we could have done differently here to try and see this patient earlier?
Yeah, I think that's a really hard question, and it's multifaceted, right? We want to get our patients in, we want to see them, we want to get them to the treatments they need. So we have financial counselors, and that's where you can kind of pull in the people who can help you with resources, see why they lost insurance. Was it something as a job change? Could they get COBRA? Is it something where it's a life change where maybe they could get something through the marketplace early? You have to use the resources you have within the community to try and move them along so you can get them the care they need.
So you would have encouraged this patient to keep this appointment?
Oh, for sure. Right? Because you can still get the train moving. You can get moving ahead. You can talk about, when organ function testing would be, what it would look like, go through all of the steps, work on getting your caregiver, work on getting everything in play that you need. So just because you lose insurance does not mean that we certainly can't see you. We can't talk about things, describe what things are going to look like, and help forge a plan forward together.
Yeah, no, I agree. So Mike, would this patient have benefited from holding therapy?
That's the point I was going to make, Dr. Breja, is the 2.5 months passed between the time he was biopsied and the time he got anything to control his disease. And I think this is somebody who, in retrospect, of course, but would have benefited from disease control while we were making that referral, while we were waiting for him to get into the treatment center, while we were waiting for insurance authorization for the car. I think that's one of the mistakes, or one of the misses in this case, is we should have done more to control his disease.
We'll talk about sort of obviously with the different diseases, but we're talking about holding therapy and bridging therapy. And holding therapy, as Xiao told us, is the treatment you give before apheresis. So there may be some things that come into your mind in terms of what makes an optimal holding therapy, or what you really want to avoid versus during bridging after the cells have been collected. Do you mind going through some of the maybe don'ts during holding therapy in case this patient does, like in this case, he didn't make the appointment, so he stayed with his doc. If his doc is starting new therapy, are there certain therapies they should be avoiding as holding therapy?
I think, yeah, so the answer is yes. And as Xiao mentioned earlier, everything has washout periods. And some of those washout periods range from a few days to several months in the case of bendamustine. So what are the don'ts? I would say don't give anything with a prolonged washout period. And bendamustine is notoriously the one agent that's associated with the longest washout period. And it's a little bit different between holding, where you're getting ready to collect the T cell product, and then the bridging therapy. And you want to give a treatment that will allow you to collect a healthy apheresis product. Bridging therapy, you have more options, and the only thing you have to be sure of is that that's washed out by the time the cells go back in. My recommendation, and the way we manage that here, is that we like to be part of that. We're happy to be a part of that conversation, want to be a part of that conversation. And in many cases, we have, like Xiao mentioned, our coordinator can tell you the tentative plan, what's going to happen in a week, 2 weeks, 3 weeks from now, and it makes it easy to arrange the calendar to select therapies that will fall into those windows. So I would say whatever the situation is, whatever the patient scenario is, I'd suggest having a low threshold to involve the people who are teeing the patient up for CAR, whether they've seen the patient yet or not.